Federally Qualified Health Center in South Carolina, and I'm also the owner of Dental Medicine Consulting, which is a small consulting firm that helps different programs and hospitals help to integrate medicine into dentistry and vice versa. So today I'm going to talk about something that probably has very rarely gotten a full hour of acknowledgement, and that is the dental needle. And it's an interesting concept, and as I was putting this together, it kind of dawned on me that maybe we don't spend enough time thinking about the needle overall and how it's involved in the dental practice. And through this process and through this presentation, I hope that you see how it can improve patient satisfaction and how it can be a means for practice growth. So when we talk about the hypodermic dental needle, it's most commonly used for the administration of local anesthetics, although we are seeing its use in different aspects of our profession overall. And the general population closely associates the needle with a visit to the dental office. It's actually the first thing they tend to think about. And usually when they think about it, it's not in a good way. There's usually a lot of pain, anxiety, and dissatisfaction associated with that. And fortunately, we have a study by Hamilton that came out in 1995 that actually demonstrated this, that showed that patients do think about it, and when they do, it's not in a good way. It's an interesting concept when we talk about dental lore and kind of the mythology and the stories behind dentistry that most in the general population have. I will tell you, I wanted to be a dentist since I was 6. It's something that I always wanted to be. Exactly why, I'm not exactly sure, but it's the truth. And so one thing that really stuck out with me was while I was in high school, and in order to get into different colleges, they like to see that you shadow different professions and do different things. And so while in high school, I shadowed a dentist, Dr. Blank, who was in Weirton, West Virginia. A shout out to my hometown. And I remember there was a patient there, and I was observing and shadowing, and I remember Dr. Blank had gave this injection, and that patient stood up out of the chair, and he looked at me and says, "So you want to be a dentist?" And I said, "Yeah." He said, "This is why I come to Dr. Blank. That injection didn't hurt at all." And it kind of stuck with me, and probably a big reason why I went into anesthesia and have such a fondness for anesthesia was that one interaction I had while I was in high school wanting to become a dentist. And it stuck with me, and I think it's throughout my practice now of trying to make sure patients are comfortable and understanding how that can build a practice and also make patients happy with what you're doing. The truth is that most aren't. The majority of patients have a dislike of anesthetic injection, and it closely associates dental care with needle and pain. I mean, that's what they think about. I'm going to go to the dentist, they're going to put a needle in my gums, and it's going to hurt. It is the first thing they tend to think about when considering dental care. And so it's very influential in the perception of the dental profession. And that's why we see such a high amount of phobia and anxiety. Truth is, 10% of the world's population is characterized as needle phobic. That's 10%. That is a huge number. It is listed as a formal medical condition, DSM-5, previously 4. In order for it to be considered a medical condition, there has to be an avoidance of care. The phobia is so pronounced that the patient will not seek care out of a fear of it. Now, a great study that was done by Dr. Sokolowski, who was at the University of Pittsburgh at the time, kind of looked at this, why people were scared of needles. And he kind of said it was a multifocal natured thing. There is this genetic aspect of things that way back into our ancestors, way back to the cavemen, that in order for our species to survive, we needed to avoid sharp objects, like tusks and spears and arrows. And so there's this genetic predisposition to avoid these sharp things. And on top of it, there's a learned response, which is the parents didn't like going to dentists because it hurt. Maybe they were teasing the kids that it was going to hurt, or just a previous experience where a needle went in or they had a painful outcome. And so those two things mixed together leads to this phobia and anxiety and this thought process of the needle being this very bad thing. When we look at patient dissatisfaction, it's related to most of the dissatisfaction reports. It is the #1 way dentists are judged. D. St. George's actually did the study. It was in Dentistry Today in 2004. Very good study, and it kind of looked at this group of data and found that that's the number one thing the patients judge you on as a dentist, as a dental provider, as a hygienist providing injections, whatever it may be. It's the number one way you're judged. Number two is how the front office staff works and how they treat the patient. And number three is just making sure they have convenient parking. I know it's kind of funny, and I'm sure there's a few of you out there that laugh, but if you think about being in a big city like New York or Miami, and you've ever tried to park downtown, it is pretty tough. So having good parking can be up there. But the number one way, the number one thing is how well you can give an injection. And so they are the best practice builder. If you give good injections, they will talk about you at Walmart, they'll talk about you at the Dollar General, they'll talk about you at the grocery store, at the water cooler, because people want those comfortable injections. And when there are reports of a bad dental experience, it's usually related to pain, either getting the injection or the injection really not working, patient experiencing pain. So let's talk about the practice characteristics of things and exactly what's being used and what's out there and what do we know. So Dr. Malamed did a review of needle breakage, and in that review he kind of looked at what the sales were. And when he looked at the percentage of market, he found that the majority of the purchases related to the 30 gauge needle, second was the 27 gauge, and lastly was the 25 gauge needle. Now, I have been given a little bit of an update, and it does appear that these percentages are pretty close to today's market value, although the 30 gauge needle now has about 60% of the total market. So we're still seeing the 30 gauge needle have the majority of the market. And we've seen that over the last 30 years. About 30 years ago, we saw this shift toward the use of smaller diameter needles. And why was that? Why are we seeing this shift? It's based on assumptions that there's less trauma and discomfort with a smaller needle. And that should make sense to you. You know, a smaller needle, going to do less damage, probably not hurt as bad. The truth is that most of that information came out of immunizations, which was in the arm. Actually giving injections to kids in the arm, and as they used a smaller diameter needle, there was less impact. They were having less pain, if you will. But one thing we got to remember is that giving injection in the arm is not the same as giving an injection in the mouth. And so I'm going to give you some studies later on that kind of go against this kind of assumption of there being less trauma and less pain. And we'll talk about that in a few more slides. What I want to talk about now, and I kind of want to bring it back. So I've kind of given you the introductory stuff and, you know, hopefully got you a little excited about what we're talking about. But now I kind of want to get to the bones, because here's the idea. If you want to be good at what you do, and you want patients to love you, and you want to have a good practice, you have to be able to give good injections. And in order to give good injections, you have to understand the pain process. And while there are a lot of things that have roles in a painful injection, the needle is probably the main thing the patient thinks about, and the least thing that we think about. When I go out and lecture, and I travel around, and I ask people in the audience, how many of you know what type of needle you use? I would say it's less than 1%. Less than 1% of the people in my audience actually know the type of needle that they're using. And so what I want to do with this presentation is kind of tell you why the needle is important and why you really need to think about the brand, the type, the process of the needle to improve the outcome and the satisfaction of your patient. And I can't go anywhere until we start talking about pain perception. You have to understand this pain process of the injection in order to understand the role the needle plays in it. So what is pain and where does that go? So the perception of pain is going to signal the occurrence of tissue damage. Ultimately, what pain is survival of the species. It is your body's process to say something is wrong here and we don't like it. And that's really what pain is about. Pain is there in order for you not to experience it anymore. And so the idea is that there's a noxious stimuli, something that's causing damage to the body, and that's resulting in pain. And what your body is hoping it will do is get away from whatever it is. And so that's really what pain perception is, and what I want to do is kind of take you through the process. And so in order to do that, you have to know the two main nerve fiber groups. Now, for all you nerve fiber geeks out there that are going to start saying there's more than just these two types, I am aware there are dozens upon dozens of subgroups of nerve fibers. But as to not bore you or myself, I'm only sticking to these two main fiber groups. And if you really want to know more, I'll give you an email, you shoot me a question, and we can talk about nerve fibers all the live long day if that's what you're into. But for today, I'm just going to stick to these two main nerve fiber groups, the type A and the type C. So the type A are the fast conducting fibers that's going to respond primarily to mechanical stimulation. That's the sharp and vivid perception of pain. The type A nerve fibers are closely associated with those free nerve endings, the ones that sit in the mucosa that you put the topical anesthetic on. That's also closely associated with the type A nerve fibers. The type C fibers, on the other hand, are the slow conducting fibers. They're usually related to a thermal or chemical sensation, dull, aching, burning sensation kind of pain, that perception. And so those are the two main groups. And those are the two main nerve fibers that we, as dental providers of intraoral injections, want to obtund or eliminate if possible so the patient doesn't experience pain. And so let's talk about this pain perception. So I told you what pain was. I then went ahead and told you what the two main fibers are that we look at, the type A fibers, which are that bright perceptual quality of pain, and the type C, which are kind of that burning sensation pain. And now I want to take you through the chronological aspects of a dental injection. Now, when I do this, I'm going to tell you about the different parts of the needle that react to these nerve fibers. So in the coming slides, I can tell you about the different aspects of a needle that you want to look for that are going to increase the comfort to the patient. And so here's the chronology. First step is that the needle penetrates the mucosa. So that's kind of the first step. Now we're going to skip this, holding the tissue taut and putting the topical anesthetic on. We're just really focusing on the nerve fibers. And so when the needle penetrates the mucosa, that's going to be your type A fibers, which, remember, that's your initial sharp type of pain. So as the needle penetrates the mucosa, it's those type A fibers that are going to respond and cause a perception to occur. Now, most providers, we use topical anesthetic. Benzocaine is the #1 topical anesthetic being used right now prior to injection. One thing to think about is the bevel of the needle, because it's just as important in decreasing the type A pain reaction with that mucosal penetration. If the bevel is not sharp, if the bevel is not crisp and clear and made of good quality, you're going to get a higher pain response with those particular type of bevels. So type A fibers, as the needle penetrates the mucosa, we got to think about the bevel just as much as we have to think about the topical anesthetic. Part 2 is the deposition of the anesthetic solution. So we've penetrated the mucosa, we get the needle where we want it to be, and now we're ready to give the anesthetic. Now, patients often describe this as the burning or aching pain. Now, that mostly is affiliated with that type C nerve fiber, which usually relates to the pH of the local anesthetic, sometimes the chemical makeup or molecules. But it also involves the type A nerve fibers, because as the anesthetic solution is inserted in, the tissue expands and there's impulse waves as well. So not only are you expanding tissue, but as that anesthetic solution flows in, a wave can come out and cause other nerves to be involved in that perception aspect. So some things we do already is we control the speed of deposition. We want nice and steady deposition of the anesthetic. Steady hand movement. Obviously, if our hand is moving all over the place or shaking, it's going to be more painful. And there's buffering. Actually, some people are buffering with sodium chloride that can decrease the pain on deposition. As it relates to the needle, the bore design can play an important role, and that can decrease the pressure of the solution flowing out of the needle. Finally, we have to take the needle out. And so that also involves both the type A and type C fibers. it is associated with postoperative pain. Now, a lot of that will go to the pH of the anesthetic. If there's a more acidic pH, then we can see some postoperative pain within the tissues. There's also, if you do multiple injections, you've done it once, it wasn't as successful as you hoped it would be, you have to go back in and do another one. And also with poor technique. If the technique is what we call rough-handed, it's obviously going to cause more issues to the patient. As it relates to the needle barbing, peeling, or splintering can cause a lot of tissue damage. And so when it comes to the needle quality, we want to look at the structural integrity and the design, as well as the coating that goes on the needle. These are things we probably have never thought about before, or maybe you have and you're one up on me and you're ahead of the game. But when we talk about making sure to decrease that needle withdrawal post-operative pain, we have to think about structural integrity, we have to think about the design of the needle and the coating. What they coat the needle with and how they do it plays an important role in that. So here's just a quick summary. We talk about the penetration. We want to look at the needle's bevel, the structural design, and the coating. When we talk about the deposition of the anesthetic, we want to look at the bore lumen. And when we withdraw the needle, we want to look at the bevel, the structural design, and the steel integrity, and the coating as well. And what I'm going to do now is kind of take you through those needle properties that I said are important in decreasing that pain response. Kind of give you some science behind some things and give you some ideas of how you can improve your practice. And so right now in dentistry, there's a considerable variation in how a needle is selected. Needle types, not manufacturer necessarily, that are familiar with during training is how some dentists will actually select. So I use this in dental school, and so I'm going to use this now. However, my own non-scientific research has found that most dentists have no idea what they're getting, and they usually just go with the cheapest brand that they can find. And most of the time, their assistants, their hygienists are ordering the needles, and they don't know what type of needle they're using and haven't given it much thought. There can be some peer influence. So-and-so says, hey, I got this great needle. It works really well for me. Economics, as we talked about, is usually a big issue. And the one thing I heard as I was traveling around this last year and asking these questions was that a needle is a needle. And what I hope you get, if you only take one thing from this presentation, one thing at all, it's that a needle is not just a needle. And if I can get you to agree with that, then I will consider this a very good success. Because there are a lot of differences in manufacturing and design. And so first thing I want to talk about is needle gauge. Now, the needle gauge is the diameter of a needle. And it goes right now in the United States, although I know I have people from different countries, but in the United States, the most commonly used are 25, 27, and 30 gauge needles. And the higher the gauge, the smaller the diameter. So 30 is going to be a smaller diameter needle than a 25. And I've told you already when we looked at practice characteristics that there's a shift to using smaller diameter needles. And that was based on 2006 research. A quick analysis that was done for this presentation found that we're still seeing this shift to these smaller diameter needles. And the conjecture is that the smaller needles equal smaller pain perception. Since really there's a study that was done in the 60s, but I'm going to go 1972. Studies have continually come out, 2 or 3 every decade, over and over and over again, saying that there is no difference between the gauge of the needle being used and the perception of pain by the subjects. They all hurt the same. And it goes back to that concept of if I'm giving an injection in the arm, that might be true. And on the medical side, there's research that says the smaller the diameter for immunizations, the less pain that a patient perceives. But there's something different about the wiring intraorally, the way that it's a sensory perception, that it just doesn't work the same way intraorally. And there's study upon study upon study upon study since 1972 that says there's no difference in pain perception if I use a 25 gauge or a 30 gauge. Patients just don't see it. It just doesn't exist. And so that conjecture really isn't warranted. However, what is the bevel. And when we talk about cutting surfaces, that's really what you want. It isn't to gauge using a smaller needle. You don't want a smaller needle, you want a sharper needle. And hopefully that makes sense to you. Not a smaller needle, a sharper needle. And the way that that cutting surface works dictates on this bevel, and how this bevel looks and how it's going to cut through tissue. There's 5 main types of bevel. We have a short bevel, a long bevel, a medium bevel, which doesn't look too much different from here. We have a multi-bevel, which has, as you can see, this one's straight. This has a kind of different cut to it. And then the new scalpel bevel, which is the evolution needle, which looks similar to this. And what most research is telling us is that the best needles to use for decreased force are the multi-bevel and the scalpel bevel designs. So, like I said, the roll of the bevel provide a cutting surface that offers little resistance. That's the deal. I mean, you really, the hot knife through butter analogy has probably been overused for the last 30 years. But the truth is you really want your needle to have this aspect of being like a hot knife through butter. And that should be the thought. Like when you're envisioning this needle penetrating the mucosa, it should be so easy. When you're holding your syringe, for my golf friends out there, it should be like holding a golf club. You don't want to grip too tight on that thing. You should be able to hold a syringe just like you're holding a golf club. And let it glide right on through the tissue. Real nice and easy. It shouldn't be rough. It shouldn't take hardly any pressure, any type of force. It should just nice and easily go right to where you want it to be. And as I said, as opposed to needle gauge, which I gave you all that research back here, and I don't want to give you too much data. I know we as presenters tend to do that. We love to hide behind our data. I'm not doing that. I'm just saying here's a bunch of the research since 1972. You can take with it as you want. We do have good research, good data, that says that opposed to needle gauge, most people are telling you the sharpness and structure of the bevel is going to play an important role. So let me say it one more time and hopefully it'll resonate. You don't want a smaller needle, you want a sharper one. And hopefully that'll resonate with you as you go back into your practice. Here's a great slide here that kind of shows you the force. On your left side, you're going to see just a standard, probably a long bevel needle. And over here, this is the evolution needle on the other side. You would see something similar with the force of a multi-bevel needle as well. And so you're having less force, which means you're involving less of the tissue, which is hopefully going to involve less of that pain perception. And so this is a great slide to show you where the red areas are at, as opposed to here, decreasing the force, better bevel is going to cut better, less force, less pain perception. So here's some other studies I like to throw out there. Whenever we decrease resistance to tissue, patient comfort's reported to improve. Patients like it better when you're using less force to push a needle through. We do have designs with low tissue resistance, and those are your multi-beveled and your scalpel bevel design. If anybody's still using those short bevels or those single bevel needles, you need to stop. You need to look at them. You should be using a multi-beveled or a scalpel bevel design. The scalpel design, this is a new thing, relatively new. It's a novel design. It needs less force, and if you look right here, you can see it does have this scalpel design, which, just using common sense and maybe thinking through it just a tad bit, you can see how that's going to cut the tissue a lot better, and therefore it's going to decrease that pain response. Now, obviously, this isn't a needle you're going to want to use for an inferior alveolar or nerve block injection. I mean, you don't want to put this anywhere where you're going to end up getting to anywhere near a nerve, because you could see how you could sever that. But this is great for maxillary infiltration away from nerve areas, or PDL injections even, or interceptal injections, things of that nature. It's going to give you a nice, crisp cut through the tissue and apply and deposit the anesthetic in a very better way. The other thing with the bevel is anesthetic success. So I've just spent the last couple of slides telling you how important the bevel is to decrease that pain perception. It's going, if you have a sharp and a nice designed bevel, it's going to decrease that pain response, those type A nerve fibers. The other thing that the bevel can relate to is anesthetic success. Now there is a myth out there that the bevel should be oriented toward the area to be anesthetized. It should face the bone, or make sure that bevel is wherever. And you remember this maybe from your education when you were in dental school. They would make you twist the bevel and you would show the instructor that the arrow is pointed to where you're going to anesthetize. Truth is, Steingruber, JADA 2006 proved that that's not true. They put that thing every which way and were still able to be successful with it. It didn't matter where the orientation was toward or away from the target area. It doesn't affect anesthetic success. So that orientation aspect really is not true. What is, and probably where there's a little bit of a gray area, is that it's based on the bevel displacement or deflection. It's actually whether or not the bevel is going to deflect or displace. Now there was a thought process that if you push the bevel a certain way using your knowledge of anatomy, if it hits anything you can at least get it to displace towards the area you're going. And if you think about it, that's kind of a silly thought, because that's awful unpredictable and maybe very brazen to actually say that your knowledge of anatomy is that astute that you can overcome any differences that a patient may have. The truth is it relates to the design of the needle and the bevel. And what you want from a needle is for it to actually, the force of the tissue to go straight down the shaft. The needle tip itself is asymmetric, right? If you think about how a needle looks from the side, with a bevel, it's not completely symmetric where you have just as equal amount of parts on one side as the other. And that's the part of the bevel that should make sense to you. What I'm showing you here in this particular slide is exactly what I just told you. Maybe not as eloquently as I would like, but hopefully this picture will demonstrate what I'm talking about. And so if you have the needle inserted and you want to follow what this red line is, you're going to have a force from the tissue. This is just physics, so I'm taking you back to undergrad or taking you back to high school physics, where a force is actually going to go down on the bevel this way, which can cause a displacement this way. And so you can see if you're aiming right here, that could be a problem because your needle is actually going away from the area you want to anesthetize. And so what's the solution? Well, the solution is to get a needle that is non-deflecting, that actually has a good design. A design that allows the force when it comes here to translate down the shaft this way, just as I'm taking my cursor down. And we have needles that actually are designed that way. And so that's what you want. Now, if you're buying the generic brand, if you're buying the Sam's Club brand of needles, then chances are it's going to look more like this than, say, a axe that's cutting through wood, as so. And so it does depend on the needle engineering. You want a design that allows for a centralized, balanced management of tissue force. And you wanted to think of driving a wedge or an axe by splitting wood. I mean, you really want the axe is so solid that it splits the wood instead of bending or curving. And a good sharp axe is going to go straight down the wood and not deflect one way or the other. And so we have non-deflecting needles. We have good design needles that decrease the amount of deflection. And that's really what we're looking for. And I will tell you, Dr. Malamed's book, the Handbook on Local Anesthesia, has a great picture in there where it shows how these forces need to go directly down the shaft and how that improves the outcomes and anesthetic success. And so that bevel design is very important, and why we need to get away from buying the generic or cheapest brand needle and into a needle from companies that actually put some thought into the engineering process, that are actually passionate about engineering these needles in a way that they're not going to deflect. So we talked about the bevel. And remember, we talked about the bevel in two ways. One is anesthetic success, which I just spent the last 5 minutes talking to you about. And the other way we talked about was exactly how the bevel can cut through the tissue. The next thing I'm going to talk to you about is the bore or lumen. And that's the hollow portion of the tube or the needle. So that's kind of the hollow portion, the pipe, where the anesthetic comes out. Now, the bore design correlates with patient comfort due to injection pressure. Now, there is an existing variable with provider technique. And so what does that mean? Well, if we have a larger bore needle, that means there's going to be more flow of the anesthetic. It's going to be easier to put the anesthetic into the tissue. If you as a provider decide that because it's easier to push, you're going to push a large amount of volume into the tissue right away, you're not going to decrease any of the patient pain. You're going to actually increase it. And so the thought process is that if you're going to use a needle design with a larger bore or lumen, you need to follow the same process you followed for all of your previous injections and keep it consistent with the deposition. Now when we talk, this is a great picture. When we talk about injection pressure, this is actually what it looks like. So here's your fluid that's coming down. And this is kind of how it looks. The fluid comes out, and this whole area is affected by exactly the pressure of the fluid coming into the tissue. And these little green kind of yellow things here are nerve endings or nerves. And you can see just with the flow of the solution coming in, just how much of the nerves can be affected just by the injection pressure, let alone the type C fibers that will be affected by the pH of the anesthetic. And when we talk about injection pressure, you know, there's a great couple of studies. Pashley did a study, Kudo did a study, just looking at how much pressure there actually is when I put a needle in and inject anesthetic. And it was found to be around 325 to 675 psi. And just to kind of give you some range, if you have a standard garden hose with a standard nozzle, the one that's up here, that most of us use on our garden hoses, that actually comes out at 200 and 250 psi. So next time you're watering the lawn or the garden or cleaning the car, go ahead and put your hand in front of that and kind of see how much pressure that is, because it's actually a lot. I did this the other day. I was surprised, you know, to think about that that's how much we're generating. We're actually generating more than that in a patient's mouth. Something to think about. If you're really going hardcore and you're really pushing quick, you can get up to around 675 psi. Now, I have a picture of Rocky Balboa there, but the average jab, offhanded jab of a mid-level boxer is around 650. Now, Mike Tyson's jab has been reported to be around 2,000 to 2,500. So you can see there's a difference between the real good heavyweights and Rocky Balboa. But you can think about this, that the pressure of our injection is more than that garden hose you're using to clean the car and water the lawn. It's more than that. And it's almost, if you're doing a hardcore injection and you're going a little crazy, it can be like a jab from a mid-level professional boxer. That should open your eyes there of exactly the importance of a slow deposition of anesthetic and why a bore and a lumen in a needle can be so much our friend. So injection pressure is created when the plunger of the cartridge is depressed. It creates a flow into the tissue. Now, a standard syringe, which the majority of us use, requires the operator to overcome the resistance in order to get the fluid to deposit. So you're actually having to overcome a certain amount of force to deposit the anesthetic. And so we naturally have to have some force or the anesthetic doesn't come out. I mean, you have to push the fluid in. What a larger bore or a better bore / lumen does is it allows the anesthetic to flow a little bit more freely. It provides the person injecting a little bit more control, and thus, when you look at the research, it says that a larger bore needle has been found to reduce pain and edema after injection, and that the more narrow bore needle produces jet under pressure, which is going to be a higher level PSI. And so those larger bore needles, like the Septoject XL, does work a little bit better when we look at the research. Now, the next thing I'm going to talk about here is needle coating. We've been coating needles since the 1960s. The idea is to improve coefficient of friction. And there are 2 studies that imply, they don't outright say it, because they were really just looking at adding silicone, which is really what we add to needles, that by decreasing the frictional action of the tissues, the quality of the needle tip can be maintained for a longer period of time. And so what you really want to look at is you want to look at a needle manufacturer that takes their coating of their needles very seriously, especially with silicone, because it's that silicone that allows a decrease in that coefficient of friction, the friction that would happen between the tissue and the needle. And what that does is relate to a lot of post-operative pain, but it also allows that smooth, that hot knife through butter kind of vibe on a needle if you have good siliconization on a needle as you go through. Now, Mr. Bill, and I don't know, the younger people in the audience may not know Mr. Bill, but please Google it if not. He's always getting into trouble. He's always having issues. And what we're going to talk about is complications and adverse events. And so there are some things in dentistry that are specific to the needle. And that's needle breakage. And here's an example of one. You can see the needle that's been broken off and lodged into the tissue after an IA injection. And so since the introduction of the non-reusable disposable stainless steel needle, it's pretty rare to see breakage. Now, I don't know how often breakage occurred prior to this, but I would say quite often, because we used to sharpen needles and sterilize them and use them over and over again. Now, Pogro has roughly estimated the risk of needle breakage, at least in Northern California, to be around 1 in 14 million. So it is fairly rare, but it does occur. And when it does occur, it usually relates to operator error or misinformation in the use of needle size. So it's not necessarily a manufacturing defect, it's actually the operator has an issue or there's been misinformation in what type of needle to use. And so this is from Dr. Malamed's article in 2010, and he did a summary report of broken needles, and these are the ones that you see. And basically what they found was, if you look, most of needles are going to break during an inferior alveolar nerve block injection, some during a posterior superior alveolar nerve block injection. And when we look at gauge, this is where it gets interesting. This is when we go back and we say, oh, I'm going to use a smaller gauge because it's going to hurt less. We found that that's not true. But yet what we do find is that the smaller gauge needles tend to break more than, say, a 27 gauge. So when you look at a 30 gauge needle, they're responsible for about 100 of the total reports. A 27 gauge is around 5. And that should be pretty eye-opening to you to actually see that. So how do we prevent needle breakage? So when we look at the studies that are out there, here's kind of an accumulation of the recommendations. You want to avoid using smaller gauge needles, that's 30 gauge and higher. Eliminate the practice of administering the standard inferior alveolar nerve block with a short needle. That was responsible for a lot of the issues. Never advance the needle to the point where the hub is flush with the mucosal surface. That was another issue. Every time that someone would put the hub right next to the tissue, there was a higher chance of the needle breaking. Avoid bending the needle. You don't want to produce excessive lateral force, which is why we're starting to see a lot in academia get away from the walk-back technique. That was very popular during a period of time, at least during my training, where if you came in and you hit bone too soon, then you walk back. Some instructors would tell us right away to walk back, which would be just kind of grabbing the bone and walking back. Well, as is anything, and we do call it a dental practice, we kind of learn from things, and we've learned that maybe that's not such a good idea. And so what we're seeing is this kind of step back, if you will, away from that walk back technique. And of course, you always want to exercise caution and vigilance with children. They tend to be the ones that will move very quickly. Special needs patients and dental phobic patients, all ones that can give you a quick movement and cause that needle to become dislodged. What happens if it occurs? Well, obviously, if the needle breaks off and you can still see it, try to get a hold of it. Get a cotton plier, get a hemostat, whatever you can get, pull it out, take some radiographs of the area, and kind of go from there. So there you go. A good question is, can't there be a higher number in breakages of the 30 gauge because more dentists buy that gauge needle? Yeah, that's true, but if you look at the proportions, this is a good question. If you just look at the proportions of breakage, they kind of overcome. Because remember, a 30 gauge needle is going to be around, well, the data we had, because this is from 2006 data, it's going to be around 56%. The 27 gauge was around 40%. So if you just extrapolate that data, you would get statistical significance that the 30 gauge needle has a much higher occurrence of needle breakage compared to the 27 gauge. You would expect to see a higher number here if it was just how much they're buying or how much there is. Great question, though. If the needle fragment is totally retained and it's difficult to remove, here's what you want to do. Take radiographs of the area from both the lateral and frontal planes, as well as pan if available. If you have the new CT scanning agents, great, use it, because that tends to be the best. You always want to save the hub for structural evaluation. You want to record the exact sequence of events in the patient's chart, which makes sense to you, and refer the patient for further evaluation, ENT, plastic surgeon, OMFS. I always tell everybody to make sure that you get that patient somewhere as quick as humanly possible, because you want to decrease pain and suffering, because there could be a possible involvement in a malpractice carrier. And so those are things you want to think about. But make sure you save the needle. I've heard a couple instances where everything gets thrown away, and that doesn't help the surgeon who may be removing the needle itself. And so they want to be able to take what was left and match up to make sure they're not missing anything. The other issue is needle barbing. Needle barbing does occur. Here's an example of a microscopic aspect of needle barbing, and then here, these ones is what you would see to the naked human eye, which is very difficult, but you can see a barb right there, and I know that's hard to see, and right there. But it tells you how difficult barbing is to see. And this actual picture right here is of a needle that has never been used. It just came from the manufacturer that way. It does occur when any of the time the pointer tip of the needle becomes bent, usually at microscopic levels. Barbing can occur during syringe preparation. It can go whenever you hit bone, which tends to be the most common. And they're dangerous because they can tear tissues, not only the mucosal tissue, but also nervous tissue. They can actually damage the nerves and cause permanent numbness. It's most often reported with IAMB injections, infraalveolar nerve block injections. Overall reports of barbing incidents are demonstrated between 30 and 78% of the time, usually with a higher occurrence which bone is contacted. So how do we relate this to needle design? A poorly designed needle is going to barb more than a needle that's designed correctly. Now, we do have this International Organization for Standardization. And what their job is they're supposed to say, this is the type of steel you're supposed to use, here's the minimum thickness, and we expect all of these needles to be to this particular standard. But a recent study out of the Middle East, when they looked at all these different needles, they found that there was a wide variation, that not all manufacturers follow these ISO guidelines. And so the quality of needle you're getting may not be all that great. And so you have to look at it similar to going in and purchasing plates or clothes or whatever. You know, if you get something that's made in a large manufacturing center, put together by a bunch of people who are doing it as quick and as fast as humanly possible for as cheap as possible, the quality is probably not going to be there. And it's something that's very important for you to think about, because when we have barbing occur, it can cause a lot of damage. And so how do you select a quality needle? How do you do it? Well, the one main issue we have is that there's not a lot of studies out there that says, here's the 7 main needle manufacturers, here's how their needles measure up. It would be great if we had these universal studies, but it's very hard to do. One, to find funding to do something that's for a needle is very difficult. And two, it's very hard to get through an IRB to say, I'm going to stick this patient 150 times. Sure, I'm going to take a step back and go to barbing. So what needle barbing is anytime the needle, if you look here, it's anytime the tip of the needle is going to either bend inward, which is an example here, or bend outward. And it's going to cause a ledge. When that ledge occurs, it's obvious that it can actually tear. When does this occur? Like I said, this particular picture was done from a needle that was taken right out of the box. It came this way. The majority of the time, it's usually when you hit bone, and the tip of the needle will bend in like so. And so if you have a needle that's poorly manufactured, or you've used it multiple times, you can see this barbing incidence. And so if you're looking to try to find a way if your needle is barbed or not, what Malamed's textbook and Bassett's textbook tell you to do is to run it along a piece of gauze and it'll catch. What I tell you to do is to use a new needle every time to decrease the incidence of that happening, and to buy a good needle. So how do we select quality needles? Here's what I've just told you. Here's kind of the big summary. The ideal needle characteristics: you want a multi-beveled scalpel bevel point. You want a bevel design that's centralized with a long axis of the needle. You want a larger bore needle to allow smoother deposition. You want to make sure that they have silicone coating. The appropriate metal alloy is used in the manufacturing process because that will help with barbing. You want a non-deflecting needle design and appropriate metal finishing. Ultimately, you want a design that's going to aid you to provide the most comfortable injection that you can. Like I said, we have limited comparative needle studies, but of the ones we have, there was a recent study that looked at 7 different bands, just took a microscopic assessment. They actually took the needles out, right out from the box, and just looked at them under a microscope. So these are not needles that have been used. And what they found was that the Carpio from the Harries-Kulzer company and the Teromo from the Teromo company had very good finishes. They had good metal alloy, good finishes. And the Septaject needle offered the best overall quality. And when you look, here's some of the needles. These are going to be your kind of generic brand needles. This is what they're looking like coming out of the box. And so, here's what you get. And if you think about this splintering here, you can think about the amount of tissue damage that can be done by using this particular device. When we look at selecting quality, we kind of went through that. I'm running low on time, and I want to try to get to some of these questions that are here. So there you go. Remember, History Channel's top 101 gadgets that changed the world had the hypodermic needle right behind the smartphone, radio, and television. Number 4. And the needle is usually the first thing considered by the patients, usually the last thing considered by the dentist, and it is a major portion of dental lore, and ultimately a quality hypodermic needle can improve the patient experience.